everyone. Welcome again in a new chest, Viva and oral cases. Today we have about 7 unique cases. Please concentrate. All of them are not very far from the exam scenario, especially long cases and Viva cases. Candidate one, please request control. Candidate one, are you ready?
Yes, Dr. Ami, yes.
We'll go on. Okay, let
Okay.
me let me scroll for all of you to save time. 16-year-old female patient complaining of chronic constipation, chronic dysphagia, and vomiting. Go on.
Okay. So here I'm provided with scanogram of a 16 years old patient who is presented with chronic dysphagia and chronic constipation. On the first inspection, I can see that there is dilatation of the bowel loops noted. These are large bowel loops. I can see that there are widely placed mucosal folds giving rise to hostile pattern. And okay, and however, the small bubble loops are not dilated. I'm not able to see the screen, Dr. Ami.
Yes. Okay.
Yes.
Go on.
So these are okay. However, I'm not able to see the dilated small bubble loops. Okay, and there is no pneumoperitorium seen. There is no portovenous gas seen. No pneumobilia seen. Looking at the lungs, I can see that there is some opacity noted in the right lower lung,
What
which
is your
which is seen.
next step?
So
What
I
is
would
your next?
advise, okay, so this is an emergency considering the large bowel obstruction. I would urgently advise contrast enhanced CT, chest and abdomen of this patient for further characterization of my findings. Okay, so here I'm provided with the contrast. Okay, these are the non-contrast axial CT thorax and abdomen images. I can see that some oral contrast has been given to the patient, and I can see that there is a soft tissue density mass lesion. Okay, I think these are the herniated. I think these are the herniated bubble loops. I want to see the continuity with the bubble loops. If I can see the lower cuts. Uh, okay, so I can on these images I can see that the bubble loops are seen herniated into the thoracic cavity in the posterior part. This is on the right side. So I mean, yeah, on the right side, I can see that the bubble loops are herniating on the posterolateral aspect, posterior aspect on the in the thoracic cavity. No. I think they are not herniating. I just want to see the from the upper cut, Dr. Rami. If you can please scroll from the upper cut, uppermost cut. Okay, and the patient has presented with dysphagia. Okay, now I can see that the esophagus is grossly dilated, and okay. In my routine practice, okay, I think that there is cross dilatation of the esophagus is noted and the patient has presented with dysphagia. In my routine practice, I would like to see the coronal images of this patient and also the sagittal reformats if available to characterize it better.
No surgical is available. What's your differential diagnosis? In the exam, almost the examiner will not give you
Okay,
more than two
so Dr.
sequence.
Rami,
One
okay,
second.
okay,
One
fine. So
one
okay,
second. One
fine.
second.
So okay,
One
fine.
second. Two
Yeah.
sequence, two planes like this. Really. Sometimes in one of my Viva case, he gave me in and out phase only, and he asked for complete full diagnosis. Go on. What do you think?
Okay, so I think that this patient who is presenting with dysphagia, I think that this is having the esophagus, there is severe dilatation of the esophagus noted in its entire extent, and which is from thoracic esophagus to the, I mean, which is seen of entire esophagus is noted. So this patient, I'm not able to see any filling defect. So it could represent eclasia, could be a primary eclasia
Are you
because
sure?
as
Are you sure? What do
like
you think? Look here. What do you think?
Mm,
The patient has dysphagia and constipation. Okay, let's have a look down, down, down to the end of the study. What do you think? First of all, what do you think about the esophagus? What happened in the esophagus?
the
What is this?
esophagus,
What
I
is
think,
this?
yeah, I think there is some thickening of the esophagus noted. Now I can see that there is some streak of contrast is noted in the esophagus, and I think that there's some wall thickening noted in the esophagus.
Okay.
So in my routine practice, Dr. Rami, I want to look at the corneal images to characterize it better, to know the entire
Give me
extent of
differential. Give me some differential.
First, it could be if the patient has no operative history, it could be ecclesia. Second, if I can see that there is some thickening also noted. I can see that there is some smooth thickening of the wall of the esophagus noted as well. So it could be some benign. Uh, I just want to know if the patient has
Okay.
undergone any operative procedure.
Uh, we don't know.
Okay, so it could be a pull-up surgery as well. Like if the patient has undergone any pull-up surgery, gastric pull-up surgery can also give rise to this finding, or apart from this, it could be some because I'm not able to see the stomach. I mean, I was not able to see the fundal gas, normally placed fundal gas. So it could be a result of some gastric pull-up surgery if the patient has undergone, or it could be a
Look here. Could you find anything here? What do you think? Here. Hello?
yes,
Hello?
yes, yes.
Yeah,
Hello.
yeah. The patient also has constipation. So we must have a look at the
So
lower cut.
if the patient
Hmm.
also has
And look,
constipation,
look what happened
okay,
here. So what do you think?
could be scleroderma, could be a possibility, which is giving rise to dilated esophagus and also the constipation. Uh,
Could you detect any abnormality here? Here.
Okay, I
Could you
cannot
detect?
see the anal sphincter. Yeah, there is a. I mean, the rectum is very much distended, and I'm not able to see the. I think the anal sphincter is very much constricted, and which is causing a dilatation of the rectum. Probably there is some
Okay.
neuromuscular
Okay.
disorder the patient is having.
So they do MRI. What do you think? MRI rectum and the anal canal. What do you think?
Okay. So in the MRI of rectum and anal canal, I can see that there is a marked thickening of the rectal wall noted with upstream dilatation of the rectosigmoid region. Uh, yes, there
Yes.
is marked thickening of the anal canal noted and upstream dilatation of the um,
Okay. Could
rectosigmoid.
do you think this thickening related to aggressive tumor or non-aggressive?
So this is non-aggressive as I'm not able to see any significant fat stranding and there is no infiltration of
Okay.
the surrounding mucosa. So I think this is
Okay.
more likely
Excellent.
in a benign type of thickening.
What benign type of tumor or thickening affecting esophagus and the anal canal do you think?
Okay, Crohn's could be a possibility, but it is an inflammatory cause. Crohn's can affect an entire
I'm asking about tumors. What do you think?
tumors, leiomyomas.
Yes. What is this?
Uh, okay, probably a leiomyomas. I'm not sure. Probably a
So what's
leiomyoma.
your final diagnosis?
So my final dog. Okay, so in this patient who is presenting with dysphagia and dilated rectosigmoid dilated rectum, I can see that there is circumferential thickening benign type of circumferential long segment thickening seen
Yeah,
involving the
yeah,
anal
yeah.
canal.
What's your
And
final diagnosis
so this is
collectively?
in keeping with multiple leiomyomas affecting the esophagus
And
and the anal canal.
thank you, doctor, so much. Diffuse esophageal, anal canal, and the valvular leiomyomatosis or multiple leiomyomas. What happened here? You picked up this lesion here very well, and you put your logic differential diagnosis. But you came here and struggled many times for struggle. Yes, there are achalasia, okay, but this case of very, very atypical case of achalasia. Achalasia means dilatation, either primary or secondary. This is secondary, despite the patient is 16-year-old, but it is secondary. But it is secondary to a benign tumor. That is all. Okay. Most of us face a secondary achalasia due to gastroesophageal cancer. No, there are marked mural thickening amount to form mass formation here. Where is this mass? See, this in the esophagus. This is not herniated bowel, not cancer, not anything else. This is in the esophagus. Go down, 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 esophagus, down to upper part of the stomach with subsequent marked dilatation of the esophagus. When you go down, because you must go down, this is a maybe typical case of long cases, my colleagues. Why? Because the patient has history of constipation. And if you go down, you will see this one, at least marked dilatation of the rectum, marked distension. Go down, down, down. And the wall here is very uniform, symmetrical, and normal, or maybe thin. Then when you go down, what is this? See, this is the opening, or this is the lumen. Very small, this very small part. This one, this is, and contain very faint contrast. This one, all of the surrounding soft tissue is marked mural thickening, my colleagues. Okay, so, so it is marked mural thickening of the inner canal. If you go more down, 1 second, 1 second, what is this? What is this? This is valvular leiomyoma also. So it was a case
स्टार्टिंग
of
करो बेटा
multiple. Yes,
बेटा शक्ल को पता बेटा ग्रीन वाली तो ऊपर बड़ी है डेस्क के
my colleague, please mute yourselves, please. Please. So it was a case, very nice, very atypical, diffuse, esophageal, anal, and valvular leiomyomas. Thank you so much, doctor.
Thank
Next
you.
candidate. Thank you.
Yes, sir. Good evening, sir.
Good evening. Doctor, this is, 1 second, 25-year-old male patient presented with history of back pain. Go on.
Okay, so I've been presented frontal chest radiograph of a 25-year-old male patient who has presented with chest pain. Here, the dominant abnormality that I see on the chest X-ray is the left side. Large opacity is noted with the broad-based towards the mediastinum. Um, and it is obscuring the left cardiac border. And also there is some associated left-sided pleural effusion is also noted. The hilar vessels are seen through this mass.
What's your
So,
what's your diagnosis?
sir, I believe this is an interior mediastinal mass with left-sided pleural effusion
Mm-hmm.
because
So
the aortic knuckle and descending aorta are also well seen.
what's your next
So,
step? Your
sir,
next
my
step.
next step, yeah. So there is some also some tracheal shift also noted to the right side. So my next step would be to do a CT scan of the chest.
Go on.
Okay, so I see that there is a large intermediastinal mass noted on the left side with fat contents and with fluid contents also. And also there is left lower lobe collapse and left-sided pleural effusion. The mass is basically in the anterior and superior part of the mediastinum. I don't see any calcified tissue within the mass. Um, uh, uh, Sir, this appears to be a germ cell tumor of anterior mediastinum on the left side. Yeah,
Yes.
I noticed some calcification also. Uh,
Mm.
it's a well-encapsulated germ cell tumor,
Yes.
most likely a mature teratoma of anterior mediastinum. But I'm not able to explain this pleural effusion, why this pleural effusion is coming. So I would like
Why
to
this pleural
see.
effusion? This is my question.
Yeah.
Why? What do you
So so
this?
either this teratoma has ruptured in the pleural space,
Okay.
uh,
Yes.
or it is infected that is causing the pleural effusion on the left side.
Excellent. Thank you so much. For the case of rupture, mediastinal teratoma, at least if you give the examiner some suggestion, like our friend do. So see here, I think there are some connection or bulging of the inferior part or inferior wall of the teratoma here. See?
Yes.
Okay, it may be the site of rupture, maybe. But at least if you give the examiner the logic possibilities, he will be happy. Thank you, doctor, so much. Doctor, do
Thank you,
you
sir.
know the types,
Yes,
different
sir.
type of teratoma?
Sir, I know that there is a mature teratoma and there is immature teratoma. In mature teratoma, we get this typical picture,
There are a third
well-encapsulated,
type. One second,
benign-looking
one second.
mass.
1 second, 1 second. There
Yes.
are another type, third type.
Okay. Sir, I don't know of
Hmm.
the third type.
There are three types, benign or mature, and intermediate and malignant or
Okay,
immature.
intermediate. Okay.
What
Okay.
is pathologically, what is the difference between sebaceous cyst and teratoma?
You mean dermoid cyst?
No, sebaceous.
Sebaceous cyst.
Yes.
Okay. Um, Sir, I think sebaceous cyst is kind of an implantation dermoid, and teratoma is like a germ cell tumor containing all the contents of endoderm, ectoderm, and mesoderm.
Excellent.
Um,
So teratoma contain at least two types of the tissue, endo, meso, or the three types, endo, meso, ectoderm, like this. But sebaceous cyst only is an ectodermal origin, correct?
ectodermal, yes.
What is do you think there are any pathological difference between dermoid cysts and teratoma?
So dermoid cyst, we basically call only the mature teratomas we call dermoid cysts. Uh,
Mhm.
I think dermoid cyst and mature teratoma is one and the same thing.
Okay, but the most obvious part is there are big difference between sebaceous cyst, which is one type only, ectodermal of origin, and the
Mm.
teratoma, which must contain at least two types of the tissues.
Tissues, yeah,
Thank,
yeah.
yeah, thank you, doctor, so much. Next candidate,
Thank you, sir.
Hello, sir.
welcome. Hello?
Yes, I am provided with frontal projection chest radiograph, portable supine, and
One
the
second,
patient is skeletal.
75-year-old
Oh,
female patient presented with
yes.
progressive dyspnea. Go on.
Hmm. So this radiograph is of 75-year-old female who is presented with progressive dyspnea,
Mhm.
and I can appreciate that the right-sided central venous catheter is noted with tip in the superior part of the right atrium, and the endotracheal tube is in satisfactory position at the level of the clavicles. A nasogastric tube is also in a satisfactory position well below the diaphragm, and
Mhm.
I can appreciate that there is tubing artifacts of multiple ECG leads. There are multiple rounded masses which are noted in the bilateral lungs. The largest mass in the right lung is in the right lung mid and lower zone. Further, there is
Mhm.
another large mass in the left retrocardiac region.
Yes.
The
What do you think?
mediastinum, yes,
What do you think?
based on yes. I think these are likely pulmonary metastasis, and
What is
I
your
can
next step?
appreciate. I would like to compare it with prior imaging if patient has any history of non-malignancy.
Mhm.
And if patient has no history, then I would advise staging CT chest, abdomen, and pelvis, and I would take history if there is any history of breast mass.
Okay. So what will you do?
I would advise CT chest, abdomen, and pelvis with contrast. I am provided with a CT scan of the chest in the arterial phase. I can appreciate that there are bilateral multiple pulmonary masses. Largest one is noted in the right lung. And further, I can also appreciate hypodense lesion, which is noted in the atrium.
Yes.
Left atrium, I would like to see it further. So this is likely tumor thrombus, which is extending from the mass in the left atrium.
Oh, what's your diagnosis?
Sir, I would also like to see the lung window to see if there is any endobronchial extension of the mass. So I can clearly appreciate that the mass is extending in the right bronchus. So based on these findings, my differentials include those of primary lung malignancy with the satellite nodules in the opposite left lung. And I would also like to see the breast on these CT scan images.
Yes, I will show you something here. Here. This one. What do you think?
Yes, these are the CT scan abdomen and pelvis images which are done in the portal venous phase. I would like to review the pelvis images. In the pelvis, I can appreciate that there is a large cystic lesion with internal calcifications. I would like to see the origin of the mass. I would like to
Mhm.
locate it on the sagittal images. However, in this image, I think that it is in the uterus.
So what's your
So,
diagnosis?
I my diagnosis is uterine sarcoma with the pulmonary metastasis. I would further advise a gynecological consultation for biopsy of the mass, and I would also advise multidisciplinary team meeting.
Okay. Do you have anything else to tell?
Um, in my routine practice, I would also see the bone window for any bone metastases, and I would see the liver on the windowing for any liver metastasis.
Mm-hmm. What else?
I would like to see the lymph nodes also, pelvic side
What
wall,
else? You have something of
ovaries.
concern.
Yes, I want to see the sagittal images and corneal images as well.
Okay. What should you transfer to your colleague, your clinician?
Um, yes, sir. Sorry.
What is your message to your colleague?
Uh, my message is the MTT discussion for histopathology and further management of the patient.
Okay, thank you. I'd ask you one question.
Yes.
Why do you think I bring this case specifically in our session today?
There may be some deceiving thing in this scan.
Yes, sure.
Which
I want
candidates?
to listen something from you about this. What is this?
This is your this mass. This mass, I think, I thought it is extending from the lung mass, and this is tumor thrombus. However, other possibilities include a cardiac mass.
Okay. Is this something urgent to be told to the clinician or to be discussed in MDT? What do you think?
Yeah, yes, sir. Echocardiography should be done for it.
No, why? Doctor, why? Why?
Uh,
It is established diagnosis. Okay? This
uh,
is
is there?
a left atrial mass. What will this mass do? It will go to right ventricle. Then it will go to the vessels and they cause disaster. Many infarction, many severe
Yes, sir.
cerebrovascular stroke. This is an urgent.
Yes, sir.
Okay? See,
Yes, sir.
you did
Uh,
very well, but
uh,
you lose half of the mark because this is an emergency, critical, fatal,
yes, sir. Yes, sir. Yes, sir.
fatal, very
Sir,
fatal.
I have Yes, sir. I
Yes.
have a question. Usually, I have observed that for bland thrombus, we give the critical alert because the bland thrombus, these are treated by anticoagulation. But for tumor thrombus, really, we do not give the alert because it is tumor which needs to be surgically resected and it cannot be anticoagulated.
At least, in my opinion, from our side as a radiologist, we should mention there are red flag here. Whatever the plan of treatment, of
Yes,
the
sir.
plan treatment, we clear our side. Are you agree with me?
Yes, sir. Yes, sir.
At
Sure.
least also in exam like FRCR, it is يعني 50% showy exam. You are showing your skills. If you told the examiner and if you take most of your time about this emergency, I think he will be happy. This is the point.
Yes, sir. Yes, sir.
Okay. Thank
Yes,
you
sir.
so much. Take care, my
Thank
colleagues
you, sir.
from
Thank you.
fatal red flags. Welcome. Leiomyosarcoma, leiomyosarcoma with a tumor thrombus in left atrium. Okay. Very critical. We should tell
Yes.
our colleagues, clinicians, and
Yes, sir.
they have the decision to do whatever suitable for their patient. Okay,
Yes, sir.
look here,
Yes, sir.
look,
Thank you, sir.
welcome. Next candidate. Uh,
Yes, sir.
by the way, a type of teratoma is mature and immature and is specialized. Specialized like that teratoma which contain thyroid gland, trauma ovarii. Okay. So if we wanted to talk about three types, it will be mature, immature, and specialized like stroma ovarian. Next candidate,
Yes, sir.
Doctor, this welcome this 75-year-old female patient complaining of right shoulder pain.
Okay, sir. I'm presented with right shoulder radiograph. In my usual practice, I usually review previous images if available. In this radiograph, I can appreciate that there's a soft tissue opacity in the apex of right lung. I cannot
Mm.
appreciate the right first rib completely, so I'm concerning for this associated right first rib destruction. I cannot see any evidence of pulmonary nodule within other pulmonary nodule in the right lung. The right shoulder joint shows marked atherosclerotic changes. So I'm concerning for the most likely finding is this an aggressive lesion in right apical region, which is causing erosion of the ribs. I would immediately recommend this patient CT chest with contrast and MRI brachial plexus and for to see its extent. Okay, I am presented with axial post-contrast images. Okay, I am seeing that there's a enhancing irregular mass with speculated margins in right upper zone, right apical region. I'm seeing through it to the last cut. This mass is causing erosion and destruction of right first rib, um, and it shows intestinal interface with the surrounding vessels. So I'm concerning this for a aggressive lesion, likely a Pancoast tumor. I would further refer this patient to the lung on MDT for further management, including biopsy.
Are you sure
I
this
would,
is Pancoast tumor? Hello?
yes, sir.
Are you sure this is Pancoast tumor?
Sir, yes, sir, it's a superior
Why?
sulcal tumor.
Why?
Because, sir, it's in the apical region and is causing erosion destruction of the ribs.
Okay, okay, what else?
Sir,
Hmm,
sir, it could be a metastatic deposit, sir.
I don't know. Are you sure? Hmm.
Sir,
What do you think metastatic deposit will be like this? Single, large, debatable.
sir, it could be a primary bronchogenic carcinoma, sir.
Okay, what else? Concentrate in the tumor itself. Hmm. What happened here?
Sir, it is, sir, I think involving the right, sir, vein, sir. It's right.
Hmm. Yes.
Yes, sir. It's involving the right subclavian and, sir, a brachiocephalic vein causing their marked luminal narrowing.
What else? But this is arterial phase. How could you judge arterial phase? How could you
Yes,
judge?
sir.
How could you? In arterial, judge assess arteries. What happened for the arteries here? What is this? Follow this, please.
Sir, this is, sir. Uh, Sir, it's yes, sir. It's right apical segmental branch of the right upper lobe pulmonary artery, sir.
What happened? Yes. What happened for it?
Sir, there's marked luminal narrowing, sir, with
What does it
obliteration,
mean
sir.
for you, doctor? Yes, what does it mean for you?
Sir, sir, this sir circumferential mass, sir, which is encasing the vessel, sir. The mass could be, sir. It's rising from the hilum and extending upwards, irregular margins, sir. So it could be a, sir, small cell carcinoma, sir.
See, in chest, what is the signs of infiltration, vascular infiltration? Could you tell me?
Sir, signs of vascular infiltration, sir.
Yes. What is the signs? What is the benchmark of vascular infiltration?
Sir, there would be obliteration of the lumen, sir,
Okay.
of the
Do you
vessels,
think
of
this
the,
is just obliteration?
sir, it is
Look.
invasion, sir.
So what does it mean for you?
Sir, it could be a vascular tumor, sir.
No, doctor. It may be a sign of vascular invasion because look, the tumor totally surround and markedly narrowed the right upper pulmonary artery,
Yes, sir.
correct?
Yes, sir.
And if you look here also, it is a pot. one tumor more than 90 degree. What is the science of vascular invasion in chest? Abutment of the tumor more than 90 degree.
90 degree.
90.
Yes.
In abdomen, 180. So here, 360. Here, 180. There are sure signs of vascular invasion. Besides that, the vessel is markedly attenuated. Okay, it's very important. Okay,
Yes, sir.
this is so why I bring this case? Number one, because it is a shoulder case with apical obesity. Number two, because of this vascular invasion. Okay, so we should take care of every slice. Okay, my colleagues.
Yes, sir.
Yes, and I think most what is the most common pathology of Pancoast tumor?
Sir, it's bronchogenic, sir, carcinoma of the lung, sir, in apical region.
Yes, what type?
Sir, it's
Histological
squamous cell
type.
carcinoma, sir.
Okay. If you do PET CT, code it active or not active.
Sir, it will not take uptake, sir.
Are you sure? What about small cell? If squamous cell carcinoma will not take. Okay. Let's see. What do you think?
Sir, it's taking avid uptake, sir.
Yeah. Why we should do PET CT for any chest tumor, any lung bronchogenic carcinoma? Why?
Sir, I'm not sure, sir.
See, to target the biopsy. Why? Doc, all of these necrotic centers. But if you have a look in CT, you will not see necrosis here. Okay? So
Sir,
it is better for any biopsy, most of the biopsy in tumors, my colleague, better to take from the periphery as a general rule, because most of the centers are necrotic. Okay? As a general rule. Look here. If you look here, could you detect this? Could you expect this one is a necrosis? Impossible. But
yes, sir.
the most important value of PET-CT to targeted correct biopsy. Number two, to pick up other lymph nodes, metastasis, whatever. Or if you are searching for primary, but in this case we didn't, we are not in need to know the primary. Thank you, doctor, so much. What is
Thank you, sir.
the case superior circle or Pancoast tumor? Because it is infiltrating chest wall. The difference between superior sulcus and the Pancoast tumor is infiltration of the chest wall, plus infiltration, sure signs of vascular invasion. Okay, my colleagues. And in my opinion, don't talk about the veins in arterial veins. Next candidate.
Yes, sir. Thank you,
Yes,
sir.
sir. Assalamu alaikum.
Because I'm 60-year-old male patient presented with recent frontal headache. Go on.
Okay.
I will scroll for you. Save the time.
Okay. So I've been presented with axial non-contrast enhanced CT images of this patient who has presented with a frontal mass. I will just go through
Are you sure
the
this
image.
is non-contrast?
No.
Contrast or non-contrast?
I think this is non-contrast.
What's your explanation about this
I
vessels?
don't. Okay. So yeah, the vessels are enhancing. So this is contrast enhanced CT.
Contrast or non-contrast?
I think it's non-contrast. I think it's non-contrast CT.
What do you think? Contrast or non-contrast?
I don't see the peripheral vessels, but yes, the MCA and I can see the atherosclerotic calcifications very well, and the in the petrous segment
Yes,
of the ICA. Yes, so it's
yes, I
I
think
think
why? Because if you look here at the basilar, you will see the hypergynity as the periphery. And the center, if you follow it, see, and the center is wrong. I think this is wrong context, in my opinion.
yes,
Besides that, we are trying to look even at the periphery. In contrast, we may pick up some veins, some cortical veins that take contrast enhancement. Here, I can't pick up any enhancement. Yeah, go on. What do you think?
yes. So I can see that in the left anterior frontal cortex, there is
Yes.
a hypodensity, and I don't see any, and I think there is some vasogenic edema in the white
Hmm.
matter.
Yes.
There is surrounding mass effect in the form of sulcal and gyral effacement.
What is your
So
next
I think
step?
I will do an MRI because I think there's a space occupying lesion in this location. Uh,
Okay, but it is very near from the bone. Ask for bone window.
yes, yes, yes.
Look,
Also the bone window.
look,
So
what happened?
in the bone window, I can see that there is some cortical thinning in the same location.
Okay, what
The
else?
intern also there is like a soft tissue component
Yes, yes.
on the yeah
You
on
get
the
you
left
get some
frontal.
benefit. Sorry, you get some benefit when you pick up this when you ask for bone window.
Yes.
Go on.
So these are axial FLAIR images of the same patient, and I can again appreciate the high signal intensity in the left frontal lobe. Um, I don't see a definite mass on this, but there is again mass effect in the form of sulcal and gyral effacement. I will look at this on other images,
Ask only
particularly
for one
post
next
contrast.
sequence.
Post contrast, I would look at it. These are the post contrast images of the same patient. Hmm. I don't see a definite enhancing lesion in this
Are you sure?
location.
Are you
Can
sure?
I see it again? I can see that there is a leptomeningeal enhancement in this location, and I can see vessels in the leptomeninges.
Mm-hmm.
Um,
What
however,
else?
intraparenchymally, I don't see any enhancing lesion, but there is some focal leptomeningeal enhancement in this location with increased vascularity. Um, okay, can I see it? Um, so I'm thinking of so yes, so I'm thinking of a leptomeningeal process that is
Yes.
focally involving the left frontal lobe. I would want to know the history of this patient. This can be focal in yes, left frontal mass. So
Which history do you want to ask about?
does the patient have any known malignancy, any known primary?
What else?
Because this can represent focal leptomeningeal carcinomatosis. Also, it can
Yes.
represent a focal area of infection or
What else?
inflammation,
What else?
inflammatory processes.
What else?
Um,
What is other differential diagnosis of leptomeningeal enhancement?
so the focal leptomeningeal enhancement, I will think of like in the terms of malignancy. I will also think of like um,
What is your next step?
I want to evaluate this in the other sequences as well. I would want to see the coronal and axial in case I'm missing
Don't worry
anything.
about it. What?
Infection.
Okay.
Um,
What is your next step? What will you do for this patient?
I will scan the whole neuraxis to see if there's any other similar
What
lesions.
else? What else?
I want to look at the sinuses if there's any sinus involvement, the frontal sinus in case of infection, like fungal infection that can spread to the ipsilateral.
I think it is normal. What else?
Yeah, it is normal. Any history of sarcoidosis, like focal neurosarcoidosis can cause like that, or TB, like that can also have
Okay.
involvement.
Okay. So what do you want to do with this patient?
Chest X-ray, just to see if there's any sarcoidosis. Okay, so these are axial CT post-contrast images of the same patient,
What do you
and
think?
I can see that there are bilateral nodularities involving the hilum as well as paratracheal lymphadenopathy. These
Yes.
findings are and in the lung window, I am trying to see if there are any perilymphatic nodules. I don't really appreciate them. I don't see
What's
any.
your final diagnosis?
Okay, my final diagnosis is sarcoidosis along with the neurosarcoidosis. So I will refer this patient to respiratory team for ACE levels, serum calcium levels, and treatment with steroids. Also, a neurology and neurosurgery needs to be on board. At this point, it doesn't seem to be exerting such any like mass effect, or it doesn't need to be anything doesn't need to be done for the brain findings. But for the chest, we would want to give this patient steroids and then follow up to assess response.
Thank you, doctor, so much. It was a neuro sarcoidosis. Okay, so when you ask for pulmonary CT or X-ray, you did very well. My advice for all of you, keep all the possible or the logical possibility within your differential diagnosis, as you see here. It looks like really a focal lesion, tumoral-like. But finally, even after MRI, it looks like leptomeningeal, something like this. But try to include as much as possible because here it is mainly meningeal. So talk about all the possible meningeal causes of leptomeningeal enhancement, and then the examiner will tell you if you told something he searching about it. He will tell you. He will help you. Okay.
Okay.
Mute yourself, my colleagues, please. Okay. Sometimes the examiner is waiting from you and telling you what else, what he wants a buzzword, and after that he will help you. Okay, my colleagues. The last
Okay.
candidate.
Sir, I have one question, please. Sir, what is the soft tissue thickening that is involving the bone of the skull as well in the same case, previous case, sir?
What's your one, please?
Yes, sir. So here, a soft tissue swelling is also seen extending into the soft tissue, and it was enhancing
I
on
say, okay,
post.
see, all of these are sarcoidosis. All of these are
Okay.
sarcoidosis. Okay. See.
Okay. Thank you.
Even see here in the radiopedia, they mentioned that the sarcoidosis affecting the concha. They write in the description. And this is very atypical for all of us. Look, they mentioned that I think this sinusitis is related to sarcoidosis and the concha related to sarcoidosis. So atypical. Okay. Thank you. Thank you. Last candidate.
السلام عليكم.
No, salam. Doctor, this patient, 30-year-old female patient presented with chest pain.
This
Hello?
is
Yes.
a chest MRI study of a patient of 30 years presented with chest pain, where
Yes.
I can appreciate an abnormal signal intensity at the left very high left posterior left posterior superior segment of left lower lung loop. I cannot appreciate other lesions. The lesion is adherent to the mediastinal pleura.
Yes.
I would like to examine the remaining views to exclude the invasion.
What do you
The
think?
invasion
What's your
of
differential?
my differential diagnosis would include um, superior left inferior lobe superior segment lesion, as well as the possibility of
Okay. I think
posterior
if
mediastinal.
do you think if all of this is tumor, it will be polite and will not infiltrate anything. Look here, no any infiltration.
Yes.
Okay. Think in another pathway, please. In another possibility.
Regarding the preservation of the neural exit foramina and poor definition of any infiltration of adjacent tissues, I would go with collapsed lung loop,
Yes.
maybe of central obstruction. My first possibility will be mucus plug.
What else? What else? This is collapsed lung loop, but
Mhm.
no any central obstruction. What do you think?
No central obstruction.
Yes. What do you think about the cause?
Because no central obstruction.
If I told you, look here, there are something obstructing or compressing this lung from outside and make it collapse
From
it
outside.
toward to the center. Well, so what
Uh,
do you think?
Regarding the surrounding hypointensity, I would go
Yes,
with pneumothorax.
excellent. Thank you so much. It
That's
is
very
a
hard.
pneumothorax.
Pneumothorax in
Pneumothorax
MRI.
in
Thank
MRI.
you, Dr. Rami.
Item. What happened here, my colleague? Very difficult, by the way, and in my opinion, give many possibilities because it is very difficult case. Because if I told you no, there are no any vascular bronchovascular here, bronchovascularity here. Okay. Also here, you can't detect well, except this one, except this line, other bronchovascularity. But overall, the
Mhm,
only suggesting sign that all the lung is collapsed towards the center. This is not a
mhm,
lesion. Why? This is the bronchi, the dark tubes. This is the dark tubes. This one are bronchi. Okay. So
Okay.
uh, all of this, this is bronchi. So um, talk about collapsed lung, totally collapsed towards the center, and there are no vascularity peripherally. So I suggest it may be like this. For example, I suggest it is pneumothorax in MRI. Thank you so much, doctor. Thank you for
Thank
all
you,
of
Dr.
you.
Rami. Thank you.
Goodbye. Goodbye, everyone.